Okay. A 68-year-old woman is brought into the emergency department with palpitations and chest discomfort. She gives a history of left hemiparesis 4 days ago, which has partially resolved after a few hours. She has a blood pressure of 160 on 95 mm Hg, respiratory rate of 22 breaths per minute, and a heart rate of 120 beats per minute. A CT scan of the head was organized, which shows evidence of a small cortical infarct. An ECG taken in the emergency department shows absent P waves and an irregular rhythm with a variable ventricular rate. Metoprolol was given intravenously and she was discharged once asymptomatic. Which long-term medications is she likely to be benefit from? A. Aspirin 300 mg, B. Aspirin 75 mg, C. Alteplase, D. Warfarin, and E. Low molecular weight heparin. And here we are going to explain which one of the choices we can choose. And here according to the patient history, the patient will benefit from warfarin, and we will say why we chose warfarin. Explanation. The patient has been diagnosed with atrial fibrillation. The symptoms of stroke were probably due to the patient atrial fibrillation. The main goals in managing atrial fibrillation are rhythm control and anticoagulation. As she was already managed with metoprolol, which is a rate-limiting medication, the next step is to control her CHA2, DS2, VASC score to determine if she requires anticoagulation. In her case, she would have a score of 4. One for her hypertension, and one for her age, one for her stroke history, and one for her sex. An anticoagulation such as warfarin would be benefit to reduce the risk of her stroke. Okay, atrial fibrillation and anticoagulation according to CHA2, DS2, VAS score. Okay, NICE suggests using the score to determine the CHA2, DS2, VASC score to determine the most appropriate anticoagulation strategy for atrial fibrillation. And we must offer anticoagulation to all people with a score of 2 or above, and we must consider offering anticoagulation to men with a score of 1. Okay, and here we will see what is CHA2, DS2, VS4. C is congestive heart failure, H is for hypertension or treated hypertension, A2 is age above age 75 or above 75, and age 65 to 74 years. D is for diabetes, and S2 is for prior stroke or TIA. V will be for vascular disease including ischemic heart disease and peripheral arterial disease, and S is for sex if the patient is female. And from all of these risk factors, the patients will take 1 point only for A2 for patient age. If it's 75 or above, the patient will take 2 points. And for prior stroke or TIA, the patient will take 2 points. Okay, and there is 1 point for exam if the patient's age is below 65 years and the patient has no any comorbidities. The patient don't need warfarin. There is no need for warfarin. But if the patient is 65 years or above, or the patient has at least one comorbidity, we must consider warfarin. Another alternative to warfarin, which has gained much popularity over the past decade, are DOAC or direct-acting oral anticoagulants such as apixaban, edoxaban, and rivaroxaban. There are some benefits for using DOAC compared to warfarin includ. Reduces the risk of intracranial hemorrhage. If the patient takes DOAC, it will reduce the risk of intracranial hemorrhage. And there is no need INR monitoring. If the patient is using warfarin, we must monitor the patient's INR. We must keep it between 2 to 3. But if the patient is using DOAC, like apixaban, edoxaban, or rivaroxaban, we don't need to monitor patient's INR. And DOAC has faster onset anticoagulation effect. The onset is 2 to 4 hours before the consumption. If the patient's score is 2 or above, we can consider DOAC in the patient, and for the man, if the score is if the score is 1 or above, we can consider DOAC for the patient. And there are some disadvantages of using DOAC also. There is no any specific antidote for DOAC. If the patient is poisoned with DOAC, there is no any antidote. We must consider it, and essential to be compliant, and it's very also important note. Okay, there are some secondary prevention after stroke or TIA. First, we must say what's the difference between stroke and TIA. Stroke is a syndrome of the sudden onset of focal neurological loss or presumed vascular origin lasting more than 24 hours, and TIA or transient ischemic attack is a syndrome of the sudden onset of focal neurological loss or presumed vascular origin lasting less than 24 hours. If it's more than lasting more than 24 hours, we will call it stroke, and if it's lasting less than 24 hours, we will say it TIA. And there are some important notes to remember as part of secondary prevention in stroke or TIA. Lower BP, aim for target blood pressure is 130 on 80. And we must consider that we must not decrease the patient's blood pressure in the first 48 hours. If we decrease it rapidly in the first 48 hours, there is a risk of extension of stroke. In an age of 55 or above, or black patients, for managing the patient's blood pressure, we must start calcium channel blockers. An age of 55 years above, we can start ACE inhibitor or angiotensin II receptor blockers if ACE inhibitors are not tolerated. We can add ACE inhibitor, calcium channel blockers, or TSA diuretics if target is not achieved with initial choice. And also we must think about the patient's cholesterol level, and aim is to decrease 40% in non-HDL cholesterol, and statins to be taken daily, lifelong after TIA or ischemic stroke. And note, there is also one note: statins for all, regardless of baseline cholesterol, will be useful. Regardless of baseline cholesterol, we must start statin. 80 milligram atorvastatin is recommended by both NICE and SIGN. And use antiplatelet or anticoagulation treatment in ischemic stroke or TIA. This largely depends in if atrial fibrillation is present. If atrial fibrillation present, we should use warfarin, dabigatran, rivaroxaban, apixaban, edoxaban. But if we are using warfarin, as we said, we must keep the patient's INR between 2 to 3. In acute setting, if TIA and imaging has excluded hemorrhage, we can start anticoagulation immediately. We must start anticoagulation immediately. If disabling ischemic stroke, we must defer anticoagulation treatment for 14 days from onset. And in this interim, in these 14 days, we can use aspirin 300 milligram daily for as anticoagulation. If atrial fibrillation absent, we can use clopidogrel 75 milligram OD for long-term prevention of ischemic event. If tolerant of if intolerant of clopidogrel, we can give aspirin 75 milligram OD plus dipyridamole M or 200 milligram BD. And again, if there is no tolerated, we can use either aspirin or dipyridamole alone. And for acute treatment of ischemic stroke, we must give 300 milligram of aspirin for 2 weeks for acute treatment of ischemic stroke. And there are some lifestyle advices also. Exercise is very important for the patients. Low salt diet, low cholesterol diet, weight loss, alcohol reduction, and smoke cessation will be very useful for the patients. Lastly, we must always consider carotid endarterectomy as secondary prevention in ischemic strokes. Thank you very much.